during partial nephrectomy in PT3A and metastatic disease, renal ischemia, parenchymal volume loss, and impact on renal function. To highlight a few, abstract MP4901 was a phase 3 randomized trial looking at the impact of intravenous mannitol used during renal ischemia time during nephron-sparing surgery. This was out of the MSK group. This phase 3 trial incorporated approximately 200 patients, and they found no difference at 6-month, 6-week postoperative EGFRs between the two groups. They also found no difference at 6-month renal scans between the group that received intraoperative mannitol and the group that received saline. Their conclusions from this trial were that intravenous mannitol infusion during nephron-sparing surgery does not lead to clinically relevant improvement in renal function outcomes and should be discontinued. Another abstract looked at perioperative morbidity of clamp versus off-clamp robotic partial nephrectomy. This was a multi-center randomized clinical trial, the CLOCK study out of Italy. The aim of this study was to compare perioperative morbidity after robotic partial nephrectomy. This group randomized 164 patients, 84 to clamp and 80 to off-clamp robotic partial nephrectomy. The groups were comparable in baseline features, in complication rates that were observed, and in oncological outcomes. The differences that were observed were the severity and bleeding that were perceived by the surgeon, as well as the actual calculated estimated blood loss. They saw a shift in off-clamp to clamp procedures in 41% of the cases that were intended to initially be off-clamp. 50% of this occurred during resection of the mass itself. And their conclusions were that while off-clamp partial nephrectomies were equally safe to those that were done off-clamp, a relevant rate of cases of off-clamp partial nephrectomies were not feasible later due to bleeding. In the localized ablative and active surveillance space, this abstract was presented by the group from Johns Hopkins. They looked at the results from the CIRM registry, which compared partial nephrectomy, radical nephrectomy, ablative therapies, and active surveillance. Essentially, they found that cancer-specific survival was comparable in all groups. They found overall survival was worse, as expected, in the active surveillance group. However, this was likely attributable to older age and worse health status at baseline. Their overall conclusions were that the survival rates were comparable in all groups after they adjusted for age and all comorbidities. They also concluded that patients were being appropriately selected for active surveillance. They looked at quality of life measures as well as renal function and determined that radical nephrectomy resulted in significantly worse kidney function in these patients with small renal mass. In advanced kidney cancers, the most common themes investigated were cytoreductive nephrectomy and metastatic RCC, surgery in patients with IVC tumor thrombus, role of neoadjuvant and adjuvant targeted therapies, utility of inflammatory markers, and the impact of tumor kinetics, marker kinetics, and pharmacokinetics on prognosis. This adjuvant study looking at adjuvant sunitinib in patients with high-risk renal cell carcinoma was presented from the STRAC trial. In this study, where they gave sunitinib to local regional RCC in patients that were at high risk of tumor recurrence after nephrectomy, they found that there was an over 2-year difference in median survival between the sunitinib and placebo-treated patients. In the majority of the subgroups that they investigated, particularly those patients that were at higher risk, including T3, T4, and any nodal status, had a benefit in terms of disease-free survival. There was a late-breaking abstract presented at this year's AUA, the A-PREDICT trial. This was a phase 2 study of oxitinib that was investigating the use of oxitinib in metastatic renal cell cancer in patients who were unsuitable for a nephrectomy. There were 99 patients that were included in this phase 2 study. And their endpoint primarily was the proportion of patients who were alive and without disease at 6 months. They found that approximately 39 of 65 patients, or 60% of patients, were alive without progression at 6 months. And again, these are patients who did not undergo a nephrectomy. 8 of the 65 patients, or 12%, did proceed to a nephrectomy after a median of 8.6 months, and their median overall survival was 18.7 months. They found that axitinib appeared to have a 3-month longer median progression-free survival than tezrolimus, which is the current recommended standard of care for poor-risk patients. In the space of epidemiology and evaluation and staging, the most common themes here were role of the renal mass biopsy, factors affecting the metastatic potential of renal tumors, variables that influence recurrence rates and long-term survival, and surveillance following partial and radical nephrectomy. One of the best posters that was presented out of Emory looked at the role of liquid biopsy in renal cell cancers. They evaluated circulating cell-free tumor DNA and looked at known mutations that are found in RCC. They determined that 67% of their cohort had detectable DNA mutations of those genes. 3% of the control patients had detectable DNA mutations. They were even able to detect RCC in patients with both early and advanced stages, and they showed that even a tumor as small as 1.1 centimeters, they were able to detect RCC. A second best poster was presented looking at whether or not our current guidelines are sufficient for organ-treated renal cancer. Even though recurrence rates were found to be rare in this group, only 4.4%, 42% of those recurrences occurred after 60 months. There was a trend in those late recurrences towards tumors that were PT1A and towards tumors that were grade 1. That leads us into kidney cancer guideline updates. Dr. Campbell gave us a nice presentation at the plenary on the guideline updates for localized kidney cancer. There are several differences to these guidelines as compared to the 2009 guidelines. There is no index patient that is listed for these patients. Index patients previously were defined by looking at healthy versus unhealthy patients and looking at tumor stage T1A and T1B. The panel has recognized that there is great variance in patient oncologic and functional outcomes, and they recommend counseling patients on choices to proceed with therapies rather than basing them on indexed patients. The guidelines also prioritize partial nephrectomy in the management of CT1A renal masses, which has not changed. They also recommend prioritizing nephron-sparing approaches for patients with solitary kidneys, bilateral tumors, known familial RCC, any pre-existing CKD or proteinuria. Tumor enucleation was incorporated into the updates this year, and this, although more research is needed to conclude whether this is oncologically safe, it can be considered for patients specifically with familial RCC, multifocal disease, severe CKD near dialysis, and should take into consideration the clinical switch situation for the patient, as well as tumor characteristics, including growth pattern and interface with normal tissue at time of surgery. Well-defined patient selection criteria for radical nephrectomy were incorporated into the guidelines. Physicians should consider radical nephrectomy where there is increased oncologic potential. Increased oncologic potential includes increased tumor size, high-grade unfavorable histology, an infiltrative appearance, or any locally invasive features. And again, in addition to those oncologic risks, if the following 3 criteria are present, then radical nephrectomy is preferred. High tumor complexity, in which a partial nephrectomy would be challenging even in experienced hands, no pre-existing CKD or proteinuria, a normal contralateral kidney that will likely provide an eGFR of over 45. Otherwise, a partial nephrectomy should be considered. Lastly, in looking at the guideline updates for active surveillance, what has been incorporated is that in patients with small renal masses less than 2 centimeters, active surveillance is an option for initial management, even in healthy patients. This should, of course, be included in shared decision-making with the patient and take into consideration age and other comorbidities. Thank you again to all the authors.